and good evening, everyone. I welcome you all for today's webinar on Lung Connect 2023. With immense pleasure, I would like to invite Dr. Ramesh Das, who is Senior Consultant in HOD Medical Oncology at Nemcare Hospital, Guwahati, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Yeah, good evening to all. Today's the Lung Connect CME under Forum of Global Oncology Forum. We are planning to start today's CME. That CME we have the only lung cancer. We will discuss regarding only lung cancer from the early part of the lung cancer up to the metastatic disease, along with recent advances. And we have one panel discussion. So without any delay, I invite our senior Dr. Anupam Mohantoda for his next topic.
Good evening to all. First of all, I offer my sincere thanks to the organizer for the kind invitation. Today, I will be discussing about rule and updates in chemotherapy in lung cancer. Bahar, can you share the slide, please?
Please, Vishal.
Okay. Okay, next slide, please. This is the burden of lung cancer. Where you can see number of new cases in 2020 in both sexes. Lung cancer was the fourth most common cancer after breast, head and neck, and uterine cervix. And number of new cases in 2020 in males, all ages. It is the second most causes of cancer in males. Next slide. Next slide, please. And in the below, you can see number of new cases in 2020, 72,510. And in the number of deaths, 66,279. And similarly, 5-year prevalence for all ages is 80,817. That is 5.8 lakhs per 1 lakh population. Next slide, please. And this is the evolution of therapy in lung cancer. NSCLC was once considered as a single disease until distinct subtypes characteristics identified, and the subtypes characteristically are clinically relevant for treatment planning from diagnosis. And the traditional view, lung cancer is divided into two subtypes, non-small cell and small cell. And again, non-small cell divided into squamous cell, non-squamous adenocarcinoma, large cell, etc. And in the molecular pathology, by different molecular pathways, that is EGFR, ALK, ROS1, etc. And presently, we are in an era of immunotherapy where PD-L1 expression, where it is less than 1%, 1 to 49%, and more than 50% is relevant in choosing immunotherapy, so as the tumor mutational burden, where less than 10 mutation per MB is low expression, while greater than 10 mutation per MB is higher expression of tumor mutational burden. Next slide, please. And this is the history of chemotherapy in advanced NSCLC, where in 1980s, does chemotherapy prolong survival in advanced diseases? The answer is yes. And cisplatin-based doublet do improve survival. And what are the remaining issues concerning with those chemotherapy, where toxicity like nausea, vomiting, and myelosuppression? You can see in the right side, median survival in 1970s with best supportive care was only 4 to 6 months, while with in 1980s, cisplatin-based regimen yields a median survival of 6 to 8 months. Next slide, please. And coming to the third generation agents, in 1990s, are platinum-based doublets with third generation agents superior to older doublets? And answer is yes, there. The third generation agents were vinorelbine, paclitaxel, gemcitabine, and docetaxel. And along with these third generation agents, in 1990, we had a median survival of 8 to 10 months only. Next slide, please. And in mid-late 1990s, the central question was which of the new doublets was the best? Are all of them have similar efficacy and safety? Answer, they have a similar efficacy with defined safety profile. And in dominant regimens in practice in US were carboplatin-based regimens, while in Europe, cisplatin-based regimens were most commonly used. Next slide, please. And current guidelines on neoadjuvant and adjuvant chemotherapy depend on disease stage and findings during surgery. In the pathologic stage, stage 1A, observation, no proven benefit of neoadjuvant or adjuvant chemotherapy. While in stage 1B and 2A, multidisciplinary team discusses observation versus adjuvant chemotherapy for high-risk patients, no proven benefit for neoadjuvant chemotherapy. While in stage 2B and 3A has a definite rule of chemotherapy, where adjuvant chemotherapy is recommended, and in stage 2B disease, there is no proven benefit of neoadjuvant chemotherapy. However, in stage 3 and 3B disease, that is N1 and N2 lymph nodal disease, one can consider neoadjuvant therapy or adjuvant chemotherapy or sequential chemotherapy with radiation therapy for N2 disease only. Next slide, please. And latest ESMO guidelines recommend that adjuvant chemotherapy can be considered in patients with resected stage 1B disease and a primary tumor of greater than 4 centimeters due to clear evidence of benefit. However, since these guidelines were published, stage 1B tumors of greater than 4 centimeters have been reclassified as stage 2 in the 8th edition of TNM staging. Therefore, adjuvant chemotherapy is now the standard of care for these patients. And adjuvant chemotherapy may remain on an option for patients with 1B disease who are in high risk due to factors other than the tumor size. Next slide. Chemotherapy with or without radiotherapy is the standard of care after complete resection in patients with stage 3 NSCLC. For patients with stage 3 disease, the medical oncologist should work closely with the radiation oncologist and radiologist to ensure a coherent approach. Some otherwise eligible patients may be unfit for chemotherapy due to factors such as very advanced age and presence of comorbidities or poor performance status like ECOG performance status 2 or more. Not all patients will complete their prescribed course of chemotherapy. And this is, I have already mentioned, different adjuvant treatment in different stages. Next slide, please. In the landmark LESS meta-analysis, overall survival benefit from post-operative cisplatin in early stage NSCLC, pooled analysis of 5 trials evaluating adjuvant cisplatin-based chemotherapy, and cisplatin vinorelbine most commonly used as an only combination shown to prolong overall survival, and chemotherapy led to improve overall survival with a hazard ratio of 0.89 and absolute benefit of 3.9% and 5.4% at 3 and 5 years respectively. Next slide, please. And impact of adjuvant chemotherapy in early stage NSCLC depends on the stage. Retrospective analysis of estimated absolute risk benefit for 100 patients treated with surgery and adjuvant chemotherapy based on reported stage-specific 5-year overall survival rates in control results of each clinical trial. All of the trial like CALJB, JBR, ELP, IALP, ONITA, LESS shown strikingly similar graph where in the stage 1 where stage 1 where stage 1, death without chemotherapy was marginal of 3%. In survival without chemotherapy, 64%, and survival due to chemotherapy was marginal, only 3%. While in stage 2, death without chemotherapy, 43%, survival without chemotherapy, 10%, and survival due to chemotherapy, only 10%. While in stage 3 has the highest benefit of adjuvant chemotherapy, where you can see death without chemotherapy 61%, while survival without chemotherapy is 26%, and survival due to chemotherapy 13% only. Next slide, please. How well does neoadjuvant or induction chemo work? About the same as adjuvant. In the forest plot, you can see both pre and post-operative chemotherapy found to be of similar hazard ratio. For stage 1B to 3A, neoadjuvant chemo yielded a hazard ratio of 0.87, while adjuvant chemo yielded a hazard ratio of 0.89. Sorry. Next slide, please. How has the paradigm changed? Next slide. It is the diagram showing mechanism of action of antibody drug conjugates. First, antibody binds target antigen, then it internalizes and payload release and bystander effect. ADCs may circulate as dynamic mixture of intact conjugate naked antibodies and free payload. ADCs reach tumors via capillaries, releasing some payload into tumor microenvironment as diffuse towards target. Antibody engagement, payload independent intertumor activity. Most antibody ADCs antigen complex internalize process via antigen dependent pathway. Payload release from endosomes and lysosomes, leading to apoptosis, and membrane permeable payloads affect nearby cells regardless of target antigen expression, which is a bystander effect. Next slide. Antibody is a chimeric or humanized monoclonal IgG antibody targeting a protein preferentially exposed on the tumor cell surface. Linker, it ensures payload is attached to antibody in plasma but is efficiently released in tumor cells. Linkers can be cleavable via tumor-associated factor or non-cleavable by lysosomal degradation. And the payload enhances cytotoxicity, although variable drug-antibody ratio affects efficacy and clearance. Next slide. Next slide, please. And it is the TDXD, that is the trastuzumab deruxtecan for HER2 mutated NSCLC cohort in DESTINY Lung01 trial, where you can see complete response was seen in 1 patient, partial response 25, stable disease 12 number of patients. That is mostly response or disease control rate of 90.5%, median duration of response not reached, and median PFS was 14 months. Next slide. Next slide, please. And this is the updated version of NCCN guidelines for NSCLC. This is preferred non-squamous regimens for non-squamous histology are cisplatin and pemetrexed, which is repeated in every 3 weeks for 4 cycles. And for squamous, cisplatin with or without with gemcitabine or docetaxel. And other recommendations are useful in certain circumstances like chemotherapy regimens for patients with comorbidity or patients not able to tolerate cisplatin. Then one can consider replacing cisplatin with carboplatin. And all chemotherapy regimen listed above can be used for sequential chemotherapy and radiotherapy. And for neoadjuvant systemic therapy, nivolumab 360 mg and platinum doublet chemotherapy every 3 weeks for up to 3 cycles. And platinum doublet chemotherapy option include either using cisplatin or carboplatin with paclitaxel, pemetrexed, or gemcitabine. And adjuvant systemic therapy, osimertinib 80 mg daily or with completely resected stage 1B, 3A, EGFR, exon 19 deletion, or L858R NSCLC who receive previous adjuvant chemotherapy or are ineligible to receive platinum-based chemotherapy. and another immunotherapeutic agent, atezolizumab, 840 milligram every 2 weeks, or 1200 milligram every 2 weeks, or 1680 milligram every 4 weeks for up to 1 year. Atezolizumab for patients with completely resected 2B3 or high risk patients stage 2 PD-L1 expression of greater than 1% who have received previous adjuvant chemotherapy. Next slide, please. And this is the defined regimen using for concurrent chemoradiation for non-squamous preferred carboplatin with pemetrexed or cisplatin with pemetrexed, paclitaxel with carboplatin, cisplatin, another regimen 50 milligram per meter square on days 1, 8, and 29, 36 with etoposide, 50 milligram per meter square from day 1 to 5 and 29 to 30 concurrent with concurrent thoracic RT. And for squamous, preferred regimen were paclitaxel 45 to 50 milligram per weekly with carboplatin at area under curve 2 with concurrent thoracic RT, without additional 2 cycles every 21 days for paclitaxel 200 milligram per meter square with carboplatin AUC 6. Consolidation immunotherapy for patients with unresectable stage 2-3 NSCLC, PS 0 to 1 and no disease progression after definitive concurrent chemoradiation, one can consider with durvalumab maintenance at 10 milligram per kg every 2 weeks or 1500 milligram every 4 weeks for up to 12 months with a patient with a body weight of greater than 30 kg. It is a category 1 recommendation for stage 3B disease. Next slide. Next slide, please. Nadaplatin is a second generation platinum derivative characterized by more favorable toxicity profile, lower rates of associated emesis and renal toxicity compared with cisplatin. It has been developed, studied in NSCLC. According to recent meta-analysis of this style, a significant interaction was confirmed, and it has an observed response rate of chemotherapy 55.6% for squamous histology versus 34.4% in non-squamous histology, suggesting a more potent activity of nadaplatin against squamous NSCLC. In addition to, next slide, please. And this is the combination of novel chemotherapy regimens with immunotherapy. Basically, we are going to mention 3 trials. One, Keynote 189, where first-line pembo with CT versus placebo plus CT in stage 4 non-squamous NSCLC. It is a randomized double-blinded trial, and patients with previously untreated stage 4 non-squamous NSCLC ECOG PS01 and with any PD-L1 status, no actionable EGFR ALK mutation, no symptomatic CNS mets or pneumonitis requiring treatment, where pembo 200 milligram every 2 weeks with placebo, with platinum and pemetrexed every 3 weeks, or with placebo and platinum pemetrexed every 2 weeks. They are randomized to receive 4 cycles and every 2 weekly until progressive disease or unacceptable toxic crossover from placebo allowed. And that second one is IMpower 150, where addition of atezolizumab to carbopacli combination and with bevacizumab in advanced NSCLC. It is also a randomized phase 3 study. And the third one is specific trial, where consolidation of durvalumab after concurrent chemoradiation for locally advanced unresectable stage 3 NSCLC. Patients with advanced unresectable stage 3 NSCLC without PD after definitive platinum-based concurrent chemoradiation for more than 2 cycles with World Health Organization PSO01 life expectancy of greater than 12 weeks. They were randomized to receive durvalumab at 10 milligram per kg every 2 weeks for up to 12 months versus placebo, and the treatment will continue until disease progression or unacceptable toxicity. Next slide, please. And these are the tables showing future direction in NSCLC, novel approaches for the treatment of immune refractory NSCLC, where there are immune checkpoint inhibitor used along single or in combination along with targeted therapy, chemotherapy, radiation, etc. For chemotherapy, paclitaxel, dacarbazine, carboplatin, or paclitaxel combination, or carboplatin or gemcitabine combination were used. Next slide. Thank you.
Yeah, thank you, Anupam Da, for nice presentation. We have two questions in chat box. One is, what is your take on sequential chemotherapy? Sequential therapy.
Sequential therapy may be used instead of concurrent chemoradiation in selected cases.
And second one is, other than chemotherapy, third generation EGFR TKI or immunotherapy. I think he have asked regarding adjuvant, I think this one.
Rule of adjuvant, what treatment? Targeted or chemotherapy?
Other than chemotherapy, third generation EGFR TKI or immunotherapy. I think in adjuvant context, he is asking, Dr. Gaurav.
Adjuvant context, we can use osimertinib also in early stage EGFR mutant lung cancer, and for immunotherapy in stage 3 NSCLC, where patient receive concurrent chemoradiation, we can have durvalumab immunotherapy as a maintenance therapy. For molecular driven mechanisms like EGFR positive mutant early lung cancer.
Thank you, Anupam Da, for a nice presentation.
Thank you, Miss. My pleasure.
Yeah. We have next presentation, the new paradigm in resected EGFR mutated early lung cancer by Dr. Duncan Khanickar. He is assistant professor, Dr. B. Burwa Cancer Institute, Guwahati. Dr. Khanickar, please.
Good evening. Am I audible?
Yes, you are audible.
Good evening, Umesh sir, and good evening to all the seniors, my colleagues. I'll be sharing my screen. Is my slide visible?
Yes, sir.
Okay. So once again, good evening to all, and I thank the sponsors for providing me the opportunity. So I'll be talking on newer paradigms in the treatment of resected EGFR mutant early lung cancer. To put it in a very short summary, there are actually two new paradigms that have come in the form of adjuvant treatment in resected EGFR mutant as well as EGFR wild type early lung cancer. In EGFR mutant, we have the third generation TKI osimertinib that has proven its benefit and has provided us with the much needed confidence that we lacked in the adjuvant therapy of early lung cancer. And in EGFR wild as well as in EGFR mutant cases, the role of immunotherapy in the adjuvant setting has also come, and it has also shown very good positive responses. And only time will tell whether immunotherapy will stand the test of time with regards to OS and DFS benefit. But right now, probably osimertinib will come as a practice adding role in the adjuvant setting of early lung cancer EGFR mutant. So this is Western data, and as per their data, lung cancer, the early stage of lung cancer comprises almost more than 2/3 of all lung cancer cases. And by early stage, it is defined by stage 1A and stage 1B. Any node or any locally advanced disease is considered as locally advanced lung cancer cases. As we all know, lung cancer is the leading cause of cancer death, and it's the number is rising in spite of better and good treatments that we have at hand. So, what is the definitive therapy in early stage non-small cell lung cancer? So, surgery is the primary treatment, and in addition, we aid the efficacy and we aid the survival benefit with some adjuvant therapies like adjuvant cisplatin-based chemotherapy, specifically in stage 2 and 3A. The role of adjuvant therapy in stage 1B has remained controversial, and as per recent updated data, probably the role is minimal to none in stage 1B. But whatever might be the case, the recurrence rate is still quite high. Even in early stage, as you can see, almost half of the cases recur in a 5-year interval. So we are always in need of some better adjuvant therapy, even in the early stage resected non-small cell lung cancer. So there have been a number of studies which have tried to assess the EGFR mutation status across all the stages of lung cancer, and they found that they are equally distributed as expected. So almost 30 to 40% or 30 to 50% cases come out EGFR mutant. And as we already know, EGFR mutation is quite prevalent in Asian population. So the benefit of EGFR TKI has always been more with the Asian population. So what is osimertinib? Osimertinib in short is the third generation irreversible TKI. And specifically, it is known for its action against T790M mutation. However, it has activity against the common mutations like exon 19 deletion as well as L58R. So osimertinib has been tried as an adjuvant therapy in stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. And the name of the trial was ADAURA trial. It was started in the year 2015, and they enrolled almost about 600 to 700 patients. The key inclusion criteria was age more than equal to 18 years with good performance status, with confirmed non-squamous non-small cell lung cancer with exon 19 deletion and L858R. And brain imaging actually was considered a compulsory investigation. And complete resection with negative margin was a strict inclusion criteria. So they had cases, they had patients who were allowed to have adjuvant chemotherapy, as well as patients without adjuvant chemotherapy. Patients were stratified by stage, EGFR mutant, as well as race. And osimertinib was given at the dose of 80 milligram once daily. The other arm was a placebo arm, and the primary endpoint was disease-free survival. So the inclusion criteria included adults more than equal to 18 years with primary non-squamous non-small cell lung CA stage 1B to 3A, centrally confirmed mutation, and complete surgical resection was the most important criteria amongst all. MRI or CT of the brain was compulsory. Exclusion criteria included any patient who had underwent neoadjuvant chemotherapy were actually excluded, or who had an early exposure to EGFR TKI have been excluded, and who had only segmentectomies or wedge resections were actually excluded. In addition, some side effects that are related to osimertinib, like prolonged QTC, patients who had prolonged QTC were excluded, and as well as patients with ILD. So baseline characteristics were equally stratified among the two arms. And as we can see, the Asian population comprised of almost about 40%. And stages 1B, 2, and 3 were also quite equally divided amongst the two arms. So adjuvant chemotherapy, 60% received adjuvant and 40% didn't receive. adjuvant chemotherapy. So what did they find in the early interim analysis of disease-free survival? So they found that the patients had a very good DFS, and the hazard rate was almost was 0.17. And this actually is quite good in terms of the fact that adjuvant chemotherapy usually provides much lesser benefit in terms of DFS. And as we all already know, the OS benefit is marginal, almost 4 to 5%. So this is quite a positive response of EGFR TKI to DFS in early stage lung cancer. So as you can see, the 83% reduction in the risk of disease recurrence or death with osimertinib with a very healthy hazard rate. And the 2-year DFS, as we can see, it's almost equivalent in all the stages, stage 1B, 2, and 3A. So the advantage and benefit of osimertinib is there with all the stages of non-small cell resected EGFR mutant non-squamous lung cancer. So the benefit having compared with terms of the subgroup analysis, we found that the benefit is there in all the subsets, whether they are of older age, more than equal to 65 years, whether they were smokers or non-smokers, whether Asian or non-Asian, and whether they had received adjuvant or no adjuvant. Osimertinib was found to be better. So this is just an early snapshot, and much shouldn't be looked into this. But as we can see, there is a slight benefit. It's very early to say whether there is an overall survival. So osimertinib was not the only EGFR TKI that has been tried in the adjuvant setting. People have tried erlotinib, even afatinib and gefitinib in the adjuvant setting, but the results were not quite up to the expectations. And DFS was, they provided a 2-year DFS almost 85 to 90%, but that was quite equivalent to even a placebo. So what is the major concern with recurrence in early stage non-small cell lung cancer? The issue is the type of recurrence. Now, as we can see, the distant recurrence actually has a much stronger impact on further therapy in lung cancer. And it has been found that local or regional recurrence is actually associated with much better survival and much better treatment efficacy. The concern with distant recurrence is CNS disease, and before the advent of osimertinib, we actually didn't have much of efficacy that we could find with any therapy, either chemotherapy or the TKIs, early TKIs. But osimertinib has been found to have good CNS penetration, and this has added up to its benefit if there is a CNS recurrence. So as we can see, this is just once again a repetition that osimertinib provides a good recurrence-free survival, and the distant recurrence that occur are quite lower in comparison to other TKIs, or even in those who do not receive any adjuvant therapy further after adjuvant chemotherapy. So if you compare the two arms in the ADAURA trial, one arm the osimertinib and the other arm the placebo, we find that all the distant recurrences in terms of the sites of recurrence are quite lower and in single digits compared to what we find in the placebo arm. So there is a definite advantage of osimertinib in terms of distant disease recurrence, and CNS recurrence is quite low if we give the patient the benefit of osimertinib. This is once again repetition, which shows that CNS recurrences is quite low with osimertinib. And so what about the safety of osimertinib? Now, as is quite common with all the TKIs, diarrhea, rashes are quite common. It is the same with osimertinib, and any grade 3 or grade 4 events with osimertinib are actually quite low, and the concerns of QTc prolongation and worsening of interstitial lung disease will always be there with TKIs. But even then, even the updated analysis of the ADAURA trial has shown that osimertinib doesn't worsen the grade of adverse effects, even if the osimertinib is continued for 2 to 3 years. So as you can see, diarrhea is quite common, and skin rashes, dry skin, pruritus are common. So as we already know, and as we have already discussed, the adjuvant therapy, chemotherapy that we use in early stage lung cancer, that provides a benefit of only 5 to 10%. And we usually give the patients almost roughly 4 cycles of adjuvant chemotherapy. And in the ADAURA trial as well, they were given a minimum of average of 4 cycles. Some patients also received 6 cycles. So is there an added benefit of osimertinib after adjuvant chemotherapy? Although we see greater differences in the gap in the curves with adjuvant chemotherapy graph, but statistically there is no significant difference. So osimertinib works as well with or without adjuvant chemotherapy, and benefit is spread out along all the stages and along all the subgroup analysis. So if we compare the benefit of adjuvant chemotherapy and followed by osimertinib, and without adjuvant chemotherapy, only osimertinib, we find that the DFS benefit is sustained through all the stages, stage 1B, stage 2, as well as stage 3A. So there is no much difference whether we add up adjuvant chemotherapy with osimertinib. So what is the patient reported outcomes and the quality of life impact by osimertinib as per the ADAURA trial? And we find that there is not much of significant stress laid upon by osimertinib. The quality of life is well maintained. Probably the toxicity that we commonly observe with osimertinib is financial toxicity, but otherwise osimertinib provides a good quality of life to all patients, and it is sustained through the entire 2 to 3 year therapy that we usually recommend in adjuvant setting for osimertinib. So adjuvant osimertinib is the first targeted agent that has proven a good DFS benefit in patients with completely resected stage 1B, 2, and 3A EGFR mutant NSCLC. As per the updated analysis of ADAURA trial, the DFS benefit is almost more than 60% in 4 years. And although the maturity for assessing overall survival has not yet been reached, but everyone is positive enough to state that there will be a good overall survival benefit. Adjuvant osimertinib also provides a clinically meaningful improvement in CNS DFS compared with placebo, and the safety profile is definitely good. And median exposure and the median duration of tolerance to osimertinib has been found to be roughly 2 years. So it is quite a well-tolerated drug. And as you can already see, the quality of life was well maintained with adjuvant osimertinib treatment. So in short, we can say that adjuvant osimertinib will provide a very good practice aiding therapy to all our patients in the adjuvant setting, whether we give adjuvant chemotherapy or not. But patients should have a complete tumor resection, and they should be in stage 1B, 2, and 3 EGFR mutant NSCLC. So that's all from my side. Thank you all.
Yeah, thank you, Kanikar, for a nice presentation. One or two questions. Okay, how long we can continue this osimertinib in adjuvant setting?
As per the ADAURA trial, sir, it was planned for a 3-year therapy, but clinicians are divided, and people state that an average of 2-year therapy is enough to achieve the benefit of osimertinib.
Okay.
The only issue, sir, is the cost of osimertinib. So we have to take that also into consideration.
Suppose patient is relapsed on adjuvant therapy, then what will be the next option? Only chemotherapy or
Post osimertinib.
Yeah, post adjuvant osimertinib.
Yeah, actually, that is a good question, sir, and that's the major problem that we have, because any progression post osimertinib, we actually have exhausted the best TKI therapy for the patient. So, as per NCCN guidelines, as of today, I believe we have to assess whether there is any oligo progression. For example, if there is a solitary liver metastasis, or probably solitary lung metastasis, or maybe solitary brain metastasis. So in those cases, probably we can go for definitive local therapy, and maybe continue or restart osimertinib again. Otherwise, I believe the other option is chemotherapy, and definitely we have to again consider the option of immunotherapy as well, post chemotherapy.
Yeah, management will be same like in metastatic NSCLC with EGFR positive on osimertinib.
Yes, sir.
Dr. Das, may I add to Dr. Duncan?
Yeah. Yes.
So I completely agree with Dr. Duncan that we need to see whether the level of progression, and we need to take a call accordingly. If it is a solitary brain lesion, mostly the failures will be in the brain. So if it is a solitary brain lesion, we can definitely address with a surgery follow or radiotherapy, depending on the number of lesions. But in addition to that, we need to remember that T790M mutation, it is not a static mutation like EGFR. So it is a dynamic mutation. There is a spatio-temporal variation with the mutation. So what happens is, when we give osimertinib, there is a pressure, there is a selection pressure on the tumor cells which are positive for T790M. And most of the T790M positive cells, they are down-regulated. So we have published a series on this in SAJC, where we have, from Dr. Ullah's unit in Rajiv Gandhi, the patients have been given osimertinib. Progression after a few months, less than expected total PFS, which do occur in 20-30% of cases. And in 2 such patients, we have done again T790M both in liquid and solid. It was negative after osimertinib. Then we have again started on erlotinib. The PFS is there for 4 more months, and then we have given docetaxel because the PS of patient was really good and patient tolerated well. So although the PFS is not really great, but post osimertinib, frankly speaking, we do not have any options. So this is one thing we can do. We can recheck T790M mutation both in liquid and solid. If it is negative, maybe we can try for because in those situations, the EGFR mutation is still there in the tissue. The T790M is downregulated, but EGFR is still there. So that is one of the options. Thank you.
Yeah, is it possible possible that suppose patient is on EGFR positive and we have given EGFR TKI, then subsequently he negative for EGFR TKI? Is it possible?
So EGFR usually do not become negative because, as we discussed, it is a static mutation. So it is the inherent property.
Yeah,
of the-
recently actually, and that I come across with one patient. He says refuse for solid this one biopsy, true cut biopsy from the lung. We have done T790 mutation along with EGFR also they have done. They are saying that EGFR is negative, even T790 also negative, EGFR also negative.
Yeah, so that may be due to the tumor heterogeneity, because ultimately where we do the biopsy, the entire tumor may not be driven by EGFR mutation, and that is the reason why some of the responses which we do not see with
Yeah,
the
yeah, that's one. And so in liquid, is it possible in liquid biopsy also?
So the concordance rates are nearly up to 90%. So if we do liquid biopsy enough times, we'll get that if it is there, because only we are seeing in that particular point of time. So if it is positive, but if it is negative, we cannot say anything. Yeah.
Yeah, you are right, Dr. Pradeep. Actually, that's what I believe, because as you've already correctly stated, lung cancer lesions are heterogeneous. There will be T790M mutation as well as other mutations in addition. So once we give osimertinib, there is selective downregulation or deletion of all those cells which have T790, but other cells might proliferate further. Which probably may not have the EGFR mutation as such, but may have other genetic alterations. So yeah, that's what I believe, that if there is a progression post osimertinib and it is not amenable for any local therapy, then probably a few cycles of chemotherapy might reduce the resistant cells, and then maybe we can continue the patient on osimertinib. What do you say about that?
I didn't get it completely, Dr. Rangan. Can you with me? Sorry, I missed it.
Yeah. Actually, I believe whenever there is a progression on osimertinib, and
so
it is
we'll
not
give
amenable
cycles
for
of chemotherapy and then
Yeah.
re-challenge.
Yeah.
So that is one of the options. So that is how the this T790M usually displays its properties and variation. I completely agree. In fact, Dr. Duncan, because you are there, and Dr. Umesh, Dr. Naresh, everyone is there, I'd like to see, I am going through this report as we are discussing. You can see here, today, this is the report of one of the patient who underwent surgery, CTRT followed by durvalumab, and then I got the genomic analysis done. And this is the report. We can see here, along with EGFR L58R, 858R, there's a KRAS amplification also. Right. So usually we know that KRAS mutation and
don't coexist.
EGFR mutation, that is mutation, but this is amplification. Now, whether we can go ahead with osimertinib or we need to add chemotherapy, that is a question, because we do know that KRAS mutation will alter the prognosis of EGFR. If it is a co-mutation, which is usually exclusive, but if it occurs, it will have a bad prognosis on EGFR. But this is a gene amplification. So
what is the impact of an KRAS amplification? Is it similar to a KRAS mutation?
That's what I'm asking, because this is the report just I got today.
Yeah. That is very difficult to say, actually. So I'll probably start the patient on TKI and then assess the response.
I agree. I am planning the same. We'll see for 2 to 3 months if there is then ideally we might continue. Otherwise, we might need to shift to chemotherapy.
Yeah.
So I hope.
Or maybe the combination of chemo and TKI might also.
Yeah, but see, there is no data to combine OC with chemo, right? With first generation chemo, we can combine, but there is no. The trial is yet on. The OCV plus chemotherapy, the trial is ongoing. So we do not have data yet. Dr. Umesh, do you feel?
Yeah, I think you can try with EGFR TKI. Then if responding well, then continue. Otherwise, chemotherapy.
Sure. Thank you.
Thank you.
And thank you, Duncan, for nice presentation. Our
Thank you,
next
sir.
talk is the role of bevacizumab in carcinoma lung by Dr. Nabokumar Kolita. He is the assistant professor, Kokrajhar Medical College. Dr. Nabo, please.
Thank you, Umeza, for your kind introduction, and hello, everyone. Let me share my screen first. Is the slide visible to all? Is the
Yes.
slide visible?
Visible.
Yes, yes. So that today my topic will be to discuss the role of bevacizumab in non-small cell lung cancer. So this is the Indian scenario. This is a very old data, Globocan 2012, but nevertheless in the 2020 also the scenario is more or less same. The incidence mortality and the 5 years prevalence rate is pretty high and sitting at the top. Now, regarding the initial evaluation doesn't have much to say. So we know that according to whether a patient is small cell or non-small cell lung cancer and the stage of the disease, functional status of the patient, performance status, all these things matter where we initiate or plan the treatment of the patient. Regarding the clinical manifestations, so these are not much to discuss. Histology we all know that 80 to 85% of the patient may have non-small cell lung cancer, while the others are maybe small cell or some other variants. Regarding the stage of the disease, we all know. So according to the stage of the disease, the treatment will differ. Regarding the locally advanced disease, that is the stage 2B and 3. So there's a combination treatment. Regarding the management of the lung cancer, treatment approach can be different. So this is just a repetition, the surgery where it is possible, lobectomy and pneumonectomy or segmental resection. If there is a locally advanced lung cancer, we can go for induction chemotherapy in some of the patient, and or maybe go for a combination chemoradiation. And in the stage 4 disease where we don't have much of an option, other to look for the chemotherapy and some targeted agent like bevacizumab and the immunotherapy, of course. And if the patient performance is not so good, so we have to just try to improve the quality of the life and the control the symptoms, just palliate the patient. Regarding the overview of the treatment of advanced non-small cell lung cancer, locally advanced, so we have to see number of the factors, the sites and the number and of metastases, and if the patient is symptomatic or not. So what is the histology, non-squamous versus squamous, we all know. And the presence of driver mutation is very, very important. We all see, so we all always go for to see the driver mutation along with the PD-L1 expression in the patient, and some patient specific issues like AS comorbidities and the preferences regarding the further treatment is always in our mind. Approach to non-small cell lung cancer. This is a pretty old slide. If the patient is bevacizumab eligible in driver mutation negative patient with a non-squamous histology, so we can use the doublet chemotherapy along with the bevacizumab. So, but the problem with the doublet chemotherapy is that median overall survival is just we can extend the median overall survival to as long as 11 months. So it's a pretty so over a period of time there is different doublet chemotherapy available, but with the cis-PEM regimen we have the maximum overall survival of 11 months. So this actually needs to add some other agents like bevacizumab along with the chemotherapeutic armamentarium in treatment with non-small cell lung cancer. So regarding the bevacizumab, two positive phase 3 data is available with us. One is ECOG 4599, which has given us a significant overall response rate, and the PFS and the overall survival benefit is also found to be statistically significant when the bevacizumab was combined with the paclitaxel versus the chemotherapy. And another was the AVIL trial, where there is overall survival data is not found to be significant, but there is a significant overall response rate and the PFS benefit. And regarding the efficacy finding, that these are substantiated by some other non-randomized observational trial like SAIL and ARIS trials. Regarding the ECOG 4599 data, so we all know that the patient was randomized to 1:1 arm. The arm A received paclitaxel along with bevacizumab 15 mg per meter per kilo body weight for every 3 weekly, and the other arm received only the chemotherapy, and the bevacizumab was continued post chemotherapeutic cycles of 6 cycles till the disease progression. And the primary endpoint was to see the overall survival, and the secondary endpoint is to see the overall response rate and the PFS. And we have seen the Kaplan-Meier curve that the median overall survival when we add the bevacizumab along with the chemotherapeutic doublet agent is 12.3 months versus 10.3 months with the chemotherapeutic arm alone. So the addition of the bevacizumab will give us a more overall survival benefit rather than doublet chemotherapy agent. Regarding the pronounced OS benefit, especially with the adenocarcinoma of the patients, especially with the patients with adenocarcinomas, so the response and the benefit is even more higher. There is a median overall survival of 14.2 months versus 10.3 months with the paclitaxel and carboplatin. And there is also improved progression-free survival. So the median progression-free survival with the addition of the bevacizumab was 6.2 months versus 4.5 months with the compared to the chemotherapeutic arm alone. Regarding the overall response rate, it was 35% versus 15%. So regarding the second trial, that is the AVIL trial, it was previously untreated stage 3B and stage 4 recurrent non-squamous cell lung cancer patients were included, and it was randomized into different category. In arm A, they have received the bevacizumab 7.5 mg per kilo along with the GEM-CIS combination, and other arm, two arm, they have received the placebo along with the GEM-CIS, and in the arm D, they have received the bevacizumab 15 mg per kilo body weight along with the GEM-CIS combination, and the bevacizumab was continued post chemotherapeutic cycles of 6 cycles till the disease progression. So basically, it just compared the bevacizumab 7.5 mg per kilo body weight versus 15 mg per kilo body weight. So we can see that the median PFS response rate, the median survival is not much different with these two combination. Regarding the SAIL, this is another trial which uses the bevacizumab in non-small cell lung cancer. So the patient with stage 3B and stage 4 with a recurrent non-squamous non-small cell lung cancer patients were included, and the standard chemotherapeutic arm with the bevacizumab 7.5 mg or 15 mg per kilo body weight every 3 weekly was included, and bevacizumab was continued as a maintenance therapy post chemotherapeutic treatment till the disease progression. And the primary endpoint was to see the safety, and the secondary endpoint was to see the time to progression, overall survival, and safety in patient developing the CNS metastasis. We can see that the overall survival is pretty much consistent that we have already seen with the other trial. The median overall survival is 14.6 months. And those patients who have achieved at least some amount of response post chemo bevacizumab combination, the continuation of bevacizumab has resulted even more greater benefit with the result of median overall survival can be as high as 18.8 months in those patients responding well to the chemo bevacizumab combination. And consistent median overall survival that we have seen with the addition of bevacizumab in combination with the chemotherapy, we have seen the ECOG 4599 and AVEL trial also, and a recent SAIL trial. So they have also received that addition of the bevacizumab along with the chemotherapy arm as will give us a better PFS and the overall survival benefit. Regarding the efficacy is almost almost same. So you can see that the HR for the overall survival in case of E4599 is 0.79, pretty much good. And with the AVEL trial, also the HR for the PFS is very good, 0.75. Regarding the EVAPERL trial, so this combination just uses the induction therapy with the PAM-CIS and BEV combination, and post that combination, if the patient is showing some amount of response, either in the form of CR, PR, or stable disease, those patients were randomized into bevacizumab arm. In arm A, they have used only the single bevacizumab maintenance, and arm B, they have persisted with the pemetrexed and bevacizumab. And we can see that the median PFS with the addition of the maintenance PEM plus bevacizumab was 10.2 months versus 6.6 months with only bevacizumab. So maintenance with the chemo and bevacizumab may give us a better progression-free survival. And PFS from the randomization, it was also pretty much similar, 7.4 months versus 3.7 months with the bevacizumab maintenance. Regarding the PFS subgroup analysis, so the response was higher with the good performance status, and those who were never smoker, in those patients, the PFS benefit was far more greater. Regarding the overall survival from the induction, so with the BEP and PEM maintenance, we have seen that the overall median overall survival is still not reached compared to the bevacizumab arm, which is 15.7 months, which is a very good news for all of us, with a hazard ratio of 0.75. And the summary is about the adverse events. So adverse event, the percentage of grade 3 to 5 hematological adverse events is higher with the bevacizumab and the pemetrexed maintenance, and the hematological toxicity and non-hematological toxicity is higher when you compare the PEM-BEP combination with respect to the bevacizumab, but it will give us a greater overall survival and the PFS benefit. So to conclude, from the EVAPERL trial, is the first line PEM, BEV, and CIS combination followed by continuous maintenance of PEM and the bevacizumab will achieve a greater PFS and the overall survival data, but it also amounts to greater side effect in both hematological and non-hematological. Regarding the Point Break study, this is another phase 3 trial about previously untreated stage 3B or stage 4 non-squamous non-small cell lung cancer patient, and PEM carboplatin with the bevacizumab 15 mg per kilo body weight every 3 weekly was used, and in other arm they have used the paclitaxel with the bevacizumab. So they just want to see whether which chemotherapeutic line is efficacious with the bevacizumab and post bevacizumab maintenance. So we have seen from the data that it is pretty much similar. There is no any advantage with the different combination chemotherapy. Both the paclitaxel carboplatin and PEM carbo in combination with bevacizumab will give us a almost similar overall survival benefit. So regarding the PFS benefit, also there is not much to differentiate. However, some numerical advantage with the PEM carbo and BEV arm. Otherwise, it is pretty much similar. Regarding the side effect profile, it is different, where the neutropenia is more high with the paclitaxel and BEV combination, but the thrombocytopenia and fatigability there may be far more higher with the PEM carbo and BEV combination. So the side effect profile may differ. So we have to choose the patient according to that. And a more supportive care is needed with the pemetrexed arm, with the blood transfusion and the platelet transfusion is much more higher with the PEM carbo and bevacizumab arm. So to summarize that, the both combination resulted in similar efficacy. There is no any significant difference in terms of overall survival, but toxicity is slightly different and with a different combination. Category 1A recommendation as per the ESMO guideline. So bevacizumab in combination with the paclitaxel carboplatin may be offered to patients with non-squamous histology, non-small cell lung cancer. So it is reserved only for the non-squamous histology, non-small cell lung cancer. Regarding the, this is a pretty old classic guideline. So the recent guideline is based on the PD-L1 expression, but it is almost same. So if the patient is non-small cell lung cancer with the adenocarcinoma, so bevacizumab along with the chemotherapeutic arm, maybe the paclitaxel carbo or the nab-paclitaxel carboplatin may be offered to the patient along with the atezolizumab if the PDL expression is more than 1%. This is the whole guideline, nothing much to discuss. So Bev, paclitaxel carbo and the pemetrexed carboplatin along with the bevacizumab may be the combination of the patient. So regarding the non-squamous cell in the Asian population, the data is in front of us, the similar efficacy result. There is nothing much to discuss. Regarding the first line therapy and maintenance therapy that we have already discussed, bevacizumab erlotinib in lung cancer. So this is the BELIEF trial, which you all know that combination of erlotinib and bevacizumab in patient with advanced non-small cell lung cancer harboring the EGFR mutation will give us a greater advantage. We want to show that almost 37 patients were T790M mutation positive. In that category of patient, you can see that the PFS result is even more higher in combination with erlotinib and bevacizumab. So if the patient is not affordable for osimertinib, we can go for erlo and bevacizumab in that category of patient. So the result is very much similar in all the subcategories of patients. So we can see that the hazard ratio for T790M mutation positive versus negative, it was 0.37, excellent. So it is even more good efficacy in terms of female patient and with unknown BRCA1 status. So in those category of patient, we can offer the combination of anti-EGFR along with the bevacizumab. This is so the BELIEF trial has shown that benefit in combination with erlo and bev in those patients harboring the EGFR mutations. So other is the another trial. This is the JUP 25567. So similar efficacy was shown. Regarding the NE 026, this is a popular trial that we all know about a phase 3 study comparing the bevacizumab plus erlotinib in comparison to erlotinib in patients with untreated non-small cell lung cancer, those having the EGFR mutations. We can see that the PFS, the hazard ratio for the PFS was 0.63. They have estimated, and the interim analysis performed, and they have shown that the study made its primary endpoint, and the PFS was 16.9 months with the BEV and erlotinib in comparison to 13.3 months with the erlotinib alone. And though the hemorrhage, proteinuria, and hypertension is slightly higher with the bevacizumab erlotinib combination with in comparison to erlotinib, but there is no any significant difference among other toxicities. So we have to select a patient according to that. So this is all from my side. Thank you for your patient listening.
Yeah, thank you, Novo, for nice presentation. Any questions? Yeah, I think no question.
Thank you.
Yeah, thank you. Next up is effective sequencing strategy for EGFR mutated NSCLC by Dr. Venkata Prasad Babu. Venkata Pradip Babu. He is the consultant medical oncologist in Assam Cancer Care Foundation, Tezpur. Babu, please.
Thank you, Dr. Umesh Das, Dr. Naresh, and Dr. Duncan for calling me here. Am I audible, Dr. Das?
Yes, yes, audible.
Yes, yes.
Sure. Yeah. Good evening to all my colleagues and seniors. And so today my topic is very simple. We need to discuss. I am supposed to discuss about the options in the sequencing of the EGFR mutated non-small cell lung carcinoma advanced stage. So when we see the therapeutic options in first line EGFR mutated NSCLC, in 1999, we have only cisplatin based chemotherapy. In 2021, we have 2 to 3 options. In 2023, as of today, we have 3 sets of options. The first set is the TKI monotherapy. We do know that it is in very minority of patients we use first and second generation TKIs alone. Although it is not very rare, the reason being logistic constraints. So the other option is third generation TKI, which is supposed to be the best option as of now. The second set of option is usage of anti-angiogenic agents, which already is being discussed just before me. So there are 2 agents that are in evaluation. One is bevacizumab and second is ramucirumab. And third option is combination of EGFR TKI and chemotherapy, which is very lucrative option in those patients, particularly who are not very affordable and who are in the various government schemes. When we see the sequencing options, how did they differ? Or like what are the what set of patients will be able to receive the next line of therapy? So when we use either first generation TKIs or second generation TKIs, and we want to use or reserve the osimertinib or third generation TKI for the later, then only a particular set of patients who are positive for T790M will be able to receive this therapy. Rest of the patients, whether ultimately will be in so poor performance status that they will not be able to receive the therapy at all, or they might be going for chemotherapy, which is usually pemetrexed and carboplatin. The standard option, as of now, most medical oncologists practice is osimertinib upfront. So when we see why we need to use osimertinib upfront, when option is available, the reason being, we can see from the data, as medical oncologists, we are people of data. So let us see the response rates, PFS, and overall survival benefit of the first, second, and third generation TKIs. We do know that in the IPASS trial, the first comparison was between the TKI and then chemotherapy, as such in ELTAC trial also, where we have seen we are assured from the data that every alternate patient does respond to the therapy when we start patient on EGFR TKI in a confirmed EGFR mutation. That is, ELTAC trial, the response rate is nearly 58%. So making sure that at least 1 in 2 patients does respond to the therapy. And LUXLAN-3 also, where afatinib is compared with chemotherapy, it is 56% response rates. However, the median PFS is much better in second generation TKI, at least 2 months of difference compared to the first generation TKI, and tuning to the average of nearly 9 months with the first generation and 11 months with the second generation. Then came a better second generation TKI, decomatinib, with a better PFS rate of 14.7 months and claiming a OS benefit, but later on, which is strongly criticized due to the hierarchical statistical model that is used in the analysis of the decomatinib trial. Out of all this, the benefit, significant OS benefit is seen with in the FLORA trial with osimertinib, while in decomatinib trial, there is a numerical benefit, but we cannot say that is a OS benefit, which we will discuss in the later slides. This is the FLORA study design, which we all very frequently come across, which has set the standard of care to a different molecule altogether. So this is a comparison between osimertinib, 80 milligrams of once daily, as vis-a-vis EGFR TKI, either geftinib or erlotinib. And it can be given till progression. And one of the most important point we need to remember in this study is stable CNS metastases are allowed at the baseline itself during the recruitment of the patients. And second important point we need to know in the trial design is that crossover was allowed. because there was a strong benefit in the patients receiving osimertinib in the preliminary trials. So there was the trial was made in such a manner that crossover is allowed whenever there is a detection of T70M mutation for those patients who have progressed on first generation TKIs. This is on humanitarian basis, and this is at the although with the good information that this will as well can dilute the OS benefit, if at all, that can be seen with the FLARA study design, because when they are starting the trial, they are not aware that whether it can lead to OS benefit or not, because this is the first trial which has shown the OS benefit. Till then, all the TKS, they have failed to show any overall survival benefit as such. So the primary objective is response rate, secondary objective is overall survival and patient safety. What are the safety indications? When we see the PFS, we can see that the curves are separated from very first day. And this we can see in the clinical practice also. Whenever we start on a third generation TKI, even in some of the patients with first generation TKI, the response is dramatic. In most of the patients feel very nice or very good with symptomatic relief, even in bone metastasis within first week. So there are two important points which we need to know from this forest plot, that is CNS metastasis, whether they are present or not, both the subsets will benefit from the osimertinib. And that is the reason why majority of the patients do fail in the CNS when we use the alternate TKIs, anything less than third generation TKI. Coming to the EGFR mutation subtype, we do know that exon del19 do much better in terms of its biological behavior compared to exon 21 mutation with any of the EGFR TKIs. But even in those, we can see here even that exon 19 is doing much better. Although it is both are favoring osimertinib, exon 19 is doing better because it's a idealistic mutation where EGFR TKI, even first generation, works better. So in both these subsets, osimertinib is doing good. And we can see here that hazard ratio is nearly 0.46, which does mean that 54% of patients, they have been benefited in terms of prevention of progression. And when we see, although this is a classical comparison, which is not an ideal scenario, we can see the type of benefit that can be accrued to the patient when we start on a particular therapy. Here, in the first curve, we can see a LUXLUM-7 trial, afatinib versus gefitinib. Up to 12 months, the curves, they crisscross each other and almost maintaining a parallel line. And the benefit of afatinib will supersede gefitinib only after 1 year, which does mean that if patient persists on afatinib for up to 1 year, that is the median PFS we know with afatinib is nearly 11 months. If he persists for more than 12 months, then the benefit will be grossly seen in those patients when they are crossing the 12 months landmark, but not before that. When we see the same in decomatinib, the benefit can be seen, the curves can be seen separating at 6 months, but not before that. But from the osimertinib, we can see from the very first month, first week, the curve started separating. One more important point we need to note here is that although we do perceive that decomatinib is a stronger second generation TKI, in this trial, all brain metastases have been excluded from the baseline. So we do not have data whether decomatinib will really work in brain mets or not. Although occasional case reports are there, but we cannot, within the main standard trial, do not have brain metastasis patient. In afatinib trial, they are included, which constitute nearly 16% of patients. In FLARA trial, they are nearly 20% of patients. So one of the important parameters we do consider is what is the time to first subsequent treatment. The time to first subsequent treatment is nearly 25 months, that is more than 2 years in osimertinib, which is very common, unlike a few cases which we are discussing before where early progression can occur, which occurs with any therapy, but that is quite a rare phenomena and portends that we need to go for the molecular subtyping and go for whether to look for the alternative mutations that may decrease the efficacy of osimertinib in these patients. This is evolving science and we are still at a very early point in understanding. So FLARA, when we see the overall survival, the median OS is more than 3 years. We can see when we see in terms of months, it is 38.6 months compared to the standard TKI of first generation or second generation. First generation, it is 31 months. So there is nearly 9 months benefit. That is as much as the PFS benefit of the first generation. And this is despite crossover rate of 31%. So 1 in every 3 patients, they have received osimertinib ultimately. And we do know that when they receive osimertinib, they will have benefit, which means the T790M positive patients, they are definitely benefiting from osimertinib too. So what we can assure is that if a patient receives osimertinib, the chance of their living at two more years or the 3-year landmark is relatively high compared to other TKIs. So now the question comes whether we can use decomatinib followed by osimertinib or directly osimertinib, because in the ARCHER trial, patients who are on decomatinib, if they have T790M mutations, which are to the tune of 10%, they received osimertinib. But it is seen that the patients who are still surviving to the same extent, who have responded to decomatinib alone, followed by subsequent therapies, the overall survival is 34 months, whereas in those patients who received osimertinib due to T790M, they continued surviving beyond 3 years, that is nearly 36.7 months. So to say strongly that only 1 in 10% person has received one osimertinib, so we cannot actually say that osimertinib, the difference is not very high, because 9 patients have not received osimertinib in this subset. Even in those patients, when we compare the 10:1 ratio of patients, the PFS is relatively longer, or OS is relatively longer in those patients who received osimertinib compared to other therapies. And this is the caveat which we were discussing before in the decomatinib oral survival Kaplan-Meier curve. So what happened during the initiation of ARCHER trial was that there was a condition that if A is greater than B, then only compare B with C. But this decomatinib has failed to show that A is greater than B. So there is no point in, we cannot compare B with C. So this is called as a hierarchical model of statistical testing, where only if the trial or the drug achieves one endpoint, then only we can go and check the other endpoint. So the decomatinib ARCHER 1050 trial failed to show the overall response rate difference compared to the first generation TKI. So actually we cannot analyze overall survival benefit. The same is clearly mentioned in the Canadian Cancers, which states that although there is a numerical improvement in overall survival in patients with decomatinib when compared to gefitinib, as this is a hierarchical model, we cannot actually say there is a benefit, overall survival benefit with decomatinib. And this is the subgroup analysis forest plot of decomatinib. So there are some other pitfalls which were observed during the forest plot of decomatinib. Coming to this point of Asian versus non-Asian, although I am very well in AstraZeneca forum, as a scientific people, we need to discuss the truths and facts. The difference of overall survival in Asian versus non-Asian was not seen with osimertinib also in the FLARA trial. However, the PFS difference is quite significant. What happened with decomatinib is that in the PFS, there was no benefit of PFS of decomatinib seen in non-Asian population, and so same is expected in the OS. But in overall survival benefit, it is shown that the difference between Asian and non-Asian population has not been observed. So which is quite dicey thing of how it is possible. And second is the PFS benefit is seen in both exon 19 del 19 mutation as well as exon 21 mutation with decomatinib, but the same was not observed in the OS curves first plot, again, which is criticized as well. So when we see the sequencing of first generation or second generation versus osimertinib, in the LUX-Lung trials who have developed T790M mutations, the overall survival is 27.9 months if they received ofatinib upfront. the same is 30.7 months with afatinib and the subsequent therapies. Whereas in GEOTAG study, if we use afatinib followed by osimertinib, is 41.3 months, which is much bigger number to actually see and believe. So what actually happened in the GEOTAG study, which we will see that there are some criticisms with the GEOTAG study, which we need to know. So when we, out of all the EGFR mutated patients, only 1/3 of patients will be ultimately receiving the osimertinib, because some of the patients, they will either die or progress with a very, very poor performance status that they will not be able to receive any other targeted therapy. That is the reason why it's better to go with the first best therapy, hit hard, hit first. So real world evidence of T790M incidence post afatinib, that is the GEOTAG study. First of all, most important thing is it is retrospective study, it is observational analysis. Whenever we are seeing a retrospective analysis also, we are supposed to include those patients who have received or who have enrolled, who are fulfilling the criteria at the beginning. But in this GEOTAG study, the patients who are T790M not tested are also excluded, which is not really right thing, because if they are not tested, they should be included in the study. If they are negative, they can still be excluded. And the patients who died on first line afatinib were excluded. If they were included, then the OS benefit drastically reduces. And patients who could not receive second line therapy are also excluded. So basically, all the aggressive disease, the patients who are succumbing to the bad disease, they were excluded effectively. So the very good population who are responding to EGFR TKIs, who have T790M mutations, who are in good performance status, who can receive osimertinib later, and who can receive osimertinib for more than 10 months before enrollment have been included. So if a patient was in osimertinib after afatinib for only 1 month, they were excluded. They have to receive at least osimertinib for more than 10 months. So now we cannot exactly say whether the benefit of OS, which we are seeing, is due to the osimertinib or afatinib. So there is a gross dilution of the result. So the effective conclusion of this study, this slide, is that not all the patients who progress on first-line EGFR TKIs will be able to receive subsequent treatment. This is because some of the patients, they can have histological transformation also. They can be small cell transformation. We need a biopsy. And some of the patients are not willing for biopsy. Some of the patients, they are not suitable for biopsy. And some of them succumb. So it is very important to choose wisely whenever feasible. We do understand that majority of the patient may not be suitable for osimertinib due to the financial reasons, but we know that palbociclib is also very costly in the area, now that it is very much accessible. So as long as it is available and can be used, ideally we should choose osimertinib, which is really soft molecule on the patients as well as on the physicians to use. So even 31% of patients on osimertinib arm has not received any further subsequent lines of anti-cancer therapy because of the progression and extensive disease after progression on this therapy. So to sequence or not to sequence is very much clear now. So T790M is not really great. In fact, the first incidence of T790M mutation in India is reported from Rajiv Gandhi. I am co-author along with Dr. Ullah Subhatra in that paper, where we have reported out of all the patients who have progressed on first generation TKI, the incidence is nearly 52.4%, which is quite high. Then it is due to the less number of population. But as we go on adding the more number of EGFR mutations and resistance, the number usually drops up to 30 to 40%, anywhere between, because just like EGFR mutation is more common in Asian population and particularly in Indian population, T790M mutation is also relatively high in Indian population. So and the second important point is choose wisely, so that the patient gets an opportunity to use the drug for a longer time. So It is osimertinib, we all know, is very well tolerated, very safe toxicity profile, and this is one drug which has shown overall survival benefit. So with this, I end my talk. Thank you so much.
Yeah, thank you, Dr. Venkat, for a nice presentation.
Thank you, sir.
Yeah, I think no question.
Sir,
Yeah.
Dr.
yeah, very nice presentation, Dr. Venkat.
Thank you.
I just had one doubt. How do you select patients? For example, do you take into account the disease burden of the patient to decide whether to go for TKI, or do you suppose the patient has a very heavy disease burden? So do you do the thought come that you may start on chemotherapy first and then go for TKI?
So, Dr. Duncan, so if we are using osimertinib, we need not start on chemotherapy, because we can see from the curves as well as from the real life experience, we can understand that response is seen from the day one itself. So that point of starting chemotherapy actually is extrapolated from breast cancer, where we define visceral crisis. So in those patients who fit into the criteria of visceral crisis, that is before the availability of targeted therapy such as osimertinib. But if it is available, there is no doubt about to start osimertinib compared to chemotherapy. However, except in those cases where there are brain metastasis, in that too in the critical areas, had it been in the cerebellum, CP angle, patients presenting with the symptomatic, then we may go for radiotherapy followed by osimertinib. But in all other cases, it is osimertinib.
Okay. For example, suppose the patient comes with gross pleural effusion and it's quite rapid filling. So in such cases, do you may consider, or osimertinib will do the work along with ICD?
This has also been tested. So I'll tell one more case which we encountered similarly. So the rapid fillers, biopsy was done. Patient was non-smoker, adenocarcinoma, 38 years old gentleman from this Afghanistan. So we have tested in tissue which is negative for EGFR. Patient obviously is not very fit for chemotherapy, and he came in very poor PS. He was airlifted from within India, and then the EGFR mutation was tested. He has a brain mets, and EGFR mutation was tested in CSF as well as in urine. He has tested positive in CSF and urine, and osimertinib was started. He responded excellently. So if it is a driver mutation is present, whether on liquid or on solid, so it is TK at any point of time, particularly the strong TK. I cannot say that I will start on gefitinib or erlotinib in such a patient with very poor PS. Unless the situation arises that I need to give something, because in a very poor PS patient, we cannot give obviously chemo. So in those patients, usually we can start with, if there is no issue, we can start with, even in Ryle's tube, we can start with osimertinib. And if not, even EGFR first generation TK will do some work in such a very poor PS scenario where chemo is absolutely contraindicated. So from medical legal point of view also, if patient is PS is greater than 2, then obviously you cannot opt for chemo.
Correct. Okay. Can I ask one more question?
Yes.
This is a question to all. Actually, the testing for EGFR mutation takes a bit of a time. Roughly takes about maybe 15 days, 20 days. So what do you do with the patient? Do you tell him to wait for the treatment, or do you go for at least one dose of chemotherapy?
I will answer first, and then I'll request all my colleagues to answer. So it is a very common scenario that whether we send for sequencing or PCR, it will take nearly 1 week to 10 days at least. And if it is sequencing more than 2 weeks. So it's a very common practice to administer one cycle of chemotherapy and then look for the mutation. So even today I have given on chemotherapy for the patient presenting with hemoptysis. He received palliative RT2 bone metastasis. I'm waiting for the Pulmoco report.
Correct. Thank you.
Yeah, thank you, Dr. Venkat.
Thank you, sir. Welcome.
Thank you, Dr. Venkat. Now, for the next talk, I would like to invite Dr. Romesh Das for his talk on recent advancement in the treatment of EGFR NSCLC. Over to you, sir.
Yeah, thank you for kind introduction. My talk made easier by Dr. Venkat. Yeah, good evening to all. My talk is recent advance in treatment of EGFR mutated NSCLC. The talk will be discussing regarding the burden and treatment strategies of NSCLC as per NCCN guideline recommendation, understanding the emerging first-line treatment landscape and targeted therapy in EGFR.
Sir, could you please switch on your camera, please?
Oh, yes.
Thank you, sir.
Yeah. Then evaluate the efficacy and safety data of different targeted therapy in the first-line treatment options of EGFR mutated positive NSCLC and discussing the role of osimertinib in first-line treatment in metastatic NSCLC with most common EGFR mutation. Burden and treatment strategies for NSCLC. As we know, as per Globocon 2020 data, lung cancer is the second most common diagnosed cancer and representing 1 in 10 cancer diagnosed, and globally death is 1 in 5 cancer patient is due to lung cancer. NSCLC is the major histological categories of lung cancer that occurs around 80 to 85% of the cases. Median OS for metastatic NSCLC hardly 4 to 5 months with supportive care. About 5 years relative survival rate of metastatic NSCLC is 6% when patient receiving histological cytotoxic chemotherapy regimen. Patient with metastatic NSCLC on targeted or immunotherapies have the 5-year survival rate ranging from 15 to 50%. The EGFR mutation, this EGFR mutation is observed around 40% and 20% of the patient with NSCLC in ASEAN and non-ASEAN population respectively in adenocarcinoma. The incidence rate of EGFR mutation along with Indian patient approximately 20 to 23%. The EGFR mutation also are located in tyrosine kinase domain, resulting increase in kinase activity of the EGFR, leading to continuous cell proliferation. This is the basic regarding the EGFR mutated NSCLC. The most common EGFR mutation are detected in exon 19, that is exon 19 deletion, and exon 21 L85R point mutation. As we know, already discussed regarding the EGFR TKI, we have first, second, and third generation EGFR TKI depending on the efficacy and range and different receptor blockade. We have first generation elortinib and then gefitinib. First generation EGFR TKI. They are reversible EGFR, and then they act on wild as well as mutated EGFR TKI and inactive in T790M mutation. We have second generation afatinib and decomatinib. This is irreversible EGFR TKI that acts by binding EGFR, is ERBB2 and ERBB4, also inhibits the ERBB family signaling. It has broad activity to overcome the EGFR TKI resistance mutation. Then we have the third generation EGFR TKI, that is osimertinib. It has activity. It is also irreversible EGFR TKI. It has activity mainly the EGFR mutated receptor, not in the wild type EGFR, and it has specificity for EGFR T790M mutant EGFR TKI. Dr. Venkat already discussed regarding the different trial for the first generation and second generation EGFR TKI along with the third generation EGFR TKI. As we see, when we use the third generation EGFR TKI, that is osimertinib, that's showing PFS benefit around 18.9 months with OS benefit that is 38.6 months. If we see all the EGFR TKI, that this is showing the highest PFS along with OS benefit. First line treatment of EGFR mutated positive patient. Where is the best option? For selecting the EGFR TKI, we have to see the different options and goals. That is which the EGFR TKI having the longer PFS benefit, which has the highest overall response rate, which has the overall survival benefit, which acts on the CNS metastatic patient. Regarding the safety, which EGFR TKI is safe and has less toxicity. About the quality of life and prolongation of time for the first and subsequent therapy. We have to see all the different points regarding before starting EGFR TKI. Regarding the progression-free survival, if we see all these three major trials, that is Lux Lung 7, ARCERS 1050, and the FLORA trial, Dr. Venkat already discussed. In Lux Lung 7 trial, if we see the PFS curve, this PFS curve, the separation is seen at around 11 months. In ARCER 1050 trial, that separation was seen at around 6 months. And whereas in FLORA trial, that separation regarding for osimertinib versus standard EGFR TKI, separation started very early. So osimertinib showing the highest median PFS, that is 18.8 months, 18.9 months, versus other EGFR TKI, and there is early separation of PFS curve. This early separation of PFS curve indicate lower frequency for the early resistance to osimertinib as compared to early resistance to other EGFR TKI. So this is one option. Another goal. What about the different mutation status? If we see in Lux Lung 7 trial that exon 19 deletion versus exon 8, exon 21, that in exon 19 deletion in Lux Lung 7 showing that PFS was 12.7 months versus an exon 21 was 10.9 months. In decomatinib trial also showing exon 19 deletion was 16.5 months, with exon 21 was 12.3 months. Whereas in FLORA trial, both exon 19 and L85R mutation showing there is highest benefit, that is for exon 19 deletion was 21.4 months, for exon 21 was 14.4 months. So osimertinib demonstrated longest PFS regardless the mutation type. problem in scrolling. Yeah. So first point for the treatment goal was made, that is osimertinib showing the longer PFS benefit. What about the objective response rate? This is also discussed by Dr. Venkat of showing that objective response rate was highest with osimertinib, that is 80%, with median duration of response was 72.2 months. So osimertinib showing highest overall response and median duration of response. What about the overall response, overall survival? This slide also already explained by Dr. Venkat. If we see in FLORA trial, overall survival for the osimertinib was 38.6 months. So osimertinib significantly improved OS versus other comparator EGFR TKI. What about the CNS mets? As we know, inclusion of the CNS disease was seen only in the LUX-Lung-7 and the FLORA trial only. And in dacomitinib trial, that ARCER 1050 trial, they have excluded the CNS metastatic patient. In FLORA trial, they are showing that OS or median PFS for CNS mets patient is 15.2 months versus 9.6 months for the comparator arm. So osimertinib made represent a clinically significant treatment option for patient with EGFR mutated NSCLC with CNS mets. This is regarding the CNS activity, as I have already explained. So osimertinib demonstrated superior systemic PFS benefit regardless the CNS disease status. So it's showing either CNS positive or negative, showing superior PFS benefit. Regarding the safety profile, grade 3 or more drug-related adverse event was very less with osimertinib. That is, for grade 3 or more adverse event with osimertinib were reported only 32% of the patient, whereas highest with dacomitinib in ARCER trial. If we see the frequency of dose reduction was seen only 4% of the patient in FLORA trial, whereas in other trial, that is LUX-Lung-7 and ARCER's trial, showing around 38% for the 41% for the LUX-Lung-7 and around 38% patient with dacomitinib trial. So osimertinib considered to be well tolerated at its recommended dose of 80 mg. The adverse event leading to dose reduction of the second generation EGFR TKIs like afatinib and dacomitinib is more frequent. So dose discontinuation for osimertinib was 13%, for treatment discontinuation due to adverse event for LUX-Lung-7 was 6%, ARCER's trial 10%, and FLORA trial was 13%. So trial showing that this is also the osimertinib also has the good safety and well tolerated. What about quality of life? As per FLORA trial showing that there is a global quality of life improvement from the baseline with osimertinib versus other EGFR TKI, whereas in LUX-Lung-7 trial and other trials showing that quality of life is poor with the EGFR TKI. What about the first subsequent therapy? If we see in this diagram, the first subsequent therapy received after relapse in osimertinib around 68% patient received chemotherapy and around 29% patient under EGFR TKI. If we see the curve for the Kaplan-Meier curve for first subsequent therapy and second subsequent therapy, that is for first subsequent therapy with osimertinib is was 25.5 months, with second subsequent therapy was 31.1 months. So even first and second subsequent therapy also showing benefit with osimertinib. Is the sequencing is the right strategy for EGFR mutated NSCLC patient? This also discussed already by our previous speaker. What about the resistant pattern? T790M mutation is the most common driver resistance mutation after first line EGFR TKI, that is around 57% of the patient. The third generation EGFR TKI showing the high potency for the T790M mutation. And so osimertinib selectively inhibit the EGFR T790 resistance mutation and approved for the treatment of acquired T790M mutation in NSCLC patient. Regarding the subsequent second line treatment, there is only 3 out of 10 EGFR mutated patients received the first with first or second generation EGFR TKI are able to receive the second line osimertinib. If we see in this diagram, Carden's diagram, there is around 70% of the EGFR patients receive second line therapy, out of which some patients die during the first line or receiving some palliative care upon progression. Out of this 70%, 60 to 70% may receive only valid T790 test result, and out of these 60 to 70%, only 50% have the valid test result positive for T790M mutation. So why not we give all the patient in the first line osimertinib, then till to wait for the second line for relapse. So T790M resistance mutation post first line therapy cannot be predicted, and not all patients receive second line and the subsequent line therapy, and osimertinib is the only TKI have shown the statistically and meaningful OS benefit, and PFS and OS benefit is seen across all subgroup when treated with osimertinib. Osimertinib is very well tolerated and very safe toxicity profile. So giving the base drugs upfront in the first line is the best optional strategy for the patient with NSCLC. This is regarding the management of metastatic NSCLC with EGFR mutated patient. So osimertinib is the preferred first line treatment for NSCLC patient who common with EGFR mutation with exon 19 deletion along with exon 21 and 5R mutation with brain mets also. And this is the NCCN guideline showing the osimertinib is the first preferred and category 1 recommendation for patient with NSCLC with EGFR mutated patient. This is regarding the adjuvant osimertinib for the patient who is EGFR positive stage 2B and 3A or high risk stage 1B and stage 2A EGFR mutated patient NSCLC who received the previous adjuvant chemotherapy and or ineligible for platinum chemotherapy. This is for the reason Dr. Duncan already described in this trial, ADAURA trial. So osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. So FLORA is the trial, the first trial demonstrate how EGFR TKI translate PFS into OS benefit. Osimertinib improved OS versus first generation EGFR TKI in untreated EGFR mutated NSCLC and T790M NSCLC that has progressed on first line EGFR TKI. osimertinib is the only EGFR TKI reported statistically significant intracranial efficacy. So sequencing cannot be considered the best strategy, as almost 70% are not eligible for receiving osimertinib in the second line. Adverse event relating to the dose reduction are frequent in second generation EGFR TKI, and osimertinib is well tolerated at its recommended dose of 50 mg. So these data confirm that osimertinib is the first standard of care for metastatic NSCLC. Yeah, thank you.
Hello.
Yeah.
Yeah. Thank you,
If
sir.
there is no question, then we can go ahead for next talk. Am I audible?
Yes, sir. You're audible.
Yeah, our next talk is case-based panel discussion in advanced EGFR mutated NSCLC. Moderator is Dr. Naresh Yadav. He is the medical oncologist, Narayana Hridaylaya, Guwahati. Now, Dr. Naresh.
Yes, good evening, sir. Am I audible?
Yes, audible.
Yeah. So good evening, everyone. At the outset, I would like to thank AstraZeneca for organizing this meet virtually, so that we can be updated about the recent advances and certain nitty-gritties in non-small cell lung cancer. Coming to the last part of the discussion, it's a panel discussion. I would like to invite my panelists. First is Dr. Tomar Noidu. He's a senior consultant medical oncology at PRIHMS Medical College. I guess it's Tomoriba Institute of Medical Sciences, Arunachal Pradesh. Next is Dr. Uma Shankar Kutum. He's a senior consultant and head of the Department of Medical Oncology at Assam Cancer Care Foundation, Dibrugarh. Then Dr. Gautam Sharma. He's an associate professor and head HOD Department of Radiation Oncology in AIIMS Guwahati. Dr. Rajiv Paul. He's an assistant professor, surgical oncology in State Cancer Institute, Guwahati. And Dr. Dhritiman Datta, who is a consultant in Department of Radiation Oncology, ABV Regional Cancer Center, Agartala. I hope and guess all the panelists are present.
Yes.
Okay. So just for the at the outset, if anybody apart from the panelist is apart from the panelist, others like Dr. Venkat, Dr. Duncan, if they want to pitch in, they are more than welcome. I'll try to share my screen. Okay, I'm finding it difficult, just like yesterday, to share my screen. Okay, I guess the...
Yes, sir, we can see your screen.
Okay, fine. Yeah, so next slide, please. So we have a case history with a 54-year-old gentleman. He's a former smoker with 20 pack years of smoking. It's not patient years. He's a type 2 diabetic, good performance status, and he was suffering from pleuritic chest pain and shortness of breath. Next slide. He was evaluated with scans and histology, which confirmed stage 4 non-small cell lung cancer with adrenal metastasis. And histology was adenocarcinoma. Next slide. And the molecular testing showed that he was EGFR positive with L858R mutation in exon T. Next slide, please. So my first question would be to Dr. Tomar. What would be your treatment of choice in this case? Would you go for the older TKIs or the newer generation, or a combination?
So Dr. Tomar will be joining shortly.
Okay, okay.
So you
Then
can.
then Dr. Uma Shankar can take this question.
Good evening, everyone. As from today's discussion, we could easily make out the valid answer. I would definitely go for a third generation EGFR TKI osimertinib because the patient has L858R mutation plus EGFR mutation.
Okay. Anybody for a combination of a TKI with chemotherapy or bevacizumab? Anyone would go take that option over osimertinib? Okay. Dr. Uma Shankar, in your clinical practice, how many of your patients do actually start on first line osimertinib?
I have till now 2 patients. It's mainly because of the cost.
Yeah. So say out of
Yeah.
10 patients who are EGFR positive, how much actually end up receiving first line osimertinib?
I have till now only 2 patients.
Okay, okay.
Yeah.
Okay. And out of ordinary, anybody, any opinion on the generic version? I know it's not a legal thing, but anybody has any experience? Dr. Umesh can share his thoughts on this.
One of my patient in Bangladeshi version, actually, he is doing well.
Okay.
Yeah, I had the same experience during my training in the Tata Medical Center. Some patients are on generic version from the Bangladeshi brand, and they are doing well also.
I have a contradicting experience, unfortunately. I tried in a couple of my patients and both of them did miserably bad. So I would rather give a first or a second generation TKI, but then obviously that's an individual thought. Next slide, please.
Okay, just a
Yeah, Dr.
query from my
Naresh.
side.
Yes.
Hello, am I audible?
Yes,
Yes.
yes, very good.
Yeah. The thing is that like in your clinical practice, how many patients you have actually got with NSCLC with only isolated adrenal mets?
Very few. I mean, I know. I mean, till now I haven't got any patient with
Because why I'm asking this particular question, if we go through literature, it says that isolated adrenal metastasis, it occurs in 1.6 to 3.5% of the patient in NSCLC.
Yes.
And adrenal mets is more common in small cell carcinoma rather than NSCLC. If we
Yes.
head-to-head compare these two variety. So, and if we go through some literature, so they have particularly mentioned that if the isolated adrenal mets, it has to be surgically, and if the patient is not surgically fit, we have to go for like SBRT option, which actually doubles your median survival.
Absolutely. Can I know who is this? I mean, I didn't
Dr.
get.
Gautam Sharma.
Yeah. So I was actually wondering how to pitch in the radiation oncologist and the surgical oncologist, because this is purely or to a large extent a medical.
No, I'll be pitching in, you don't worry.
So, absolutely, sir. Point well taken. In fact, this is in the area of oligometastatic diseases, wherein if we have limited number of disease, you can approach these oligometastatic sites either surgically.
Even if you go through the Florida trial, no, so they have in the osimertinib arm, they had 279 patients, if I remember correctly. Okay. And out of that, only 94 patients has visceral metastasis.
Absolutely.
And I actually tried to find out that actually with adrenal mets, how many patients were there. I could not find any documentation on that.
There's no data about that, right, sir?
Yeah, they have clubbed together all the visceral mets.
Correct.
That's all I could find.
Correct. So basically, that point is very well taken, that when we have isolated sites or isolated organs of metastasis, you can still attempt a curative intent either with surgery or with radiation. And there is good enough data for brain and isolated adrenal mets, if I remember correctly.
Exactly.
Yes. But then for the discussion's sake, since we are, dealing with oral TKIs and chemotherapy.
Yeah.
So let's assume that this patient had multiple visceral metastasis,
Sure.
he was not fit for a definitive therapy. When we talk about guidelines, amongst all the different TKIs, and this point has already been elaborated by Dr. Umesh sir and Dr. Venkat, that among the different TKI options that we have, osimertinib certainly has a category 1 recommendation, and it's recommended as the preferred option in first line. Next slide, please. And obviously we have reasons in terms of the overall survival, the efficacy data, the overall survival data, and the safety data. Dr. Drithiman, I would like to ask you, whenever you're choosing your first option, what things are important for you? You look more at the survival evidence, or you look more at the safety profile when you choose a particular drug for your patient. And we can also move on to the next slide. Dr. Drithiman?
He's on mute. Please unmute him.
Now, hello.
Yes, we can hear you.
Actually, you are talking about the advanced stage of this mutated EGFR.
Yes, advanced stage.
Okay.
Yeah.
So first of all, a patient choosing the advanced stage. So I think we should think about the patient ECOG also. I mean, performance status. So we can, if we think that his performance status is okay, then we can think for this his survival. Then we can go for this efficacy also. And as far as my previous lecture, I have seen that osimertinib is a very good drug. Recently is available, though we have not used here because we don't have medical oncology. So the patient, they come usually from outside. But I think osimertinib is a very good option now we have. And what Dr. Gautam, he said in the previous lecture, with this isolated mets, we can try for RT also, radiotherapy. And we can continue this osimertinib also. For efficacy, plus overall survival, all this osimertinib, I think it will be a very good drug for us.
Well, as Dr. Drithiman has mentioned about performance status, Dr. Tomar, has he joined us? Has Dr. Tomar joined us?
Oh, he couldn't. He is busy, stuck up with some.
Okay. So, Dr. Uma Shankar, a patient comes to you with a very poor performance status, say PS3. He is bedridden. He is metastatic non-small cell lung cancer with EGFR positive. In this case, would you give him a TKI? Consider it a leap of faith and give off a TKI?
Yeah. Actually, from my experience with osimertinib, this patient has what I had experienced. He had this ILD also, interstitial lung disease. PS, her PS was 2-3. So in that case also, I have used osimertinib as a last resort, as she was an insured patient. So she did well. That's my personal experience using in patient with 2-3 PS. And she is still surviving. She is still on osimertinib. Yes, it's a very tricky situation. If the patient's party and the attendant wants to go ahead with the treatment option, then I definitely want to try it, even if it's the PS2.
Dr. Venkat, if you are with us, what would you do in such a scenario? I don't think Dr. Venkat is with us. Dr. Umesh?
Yeah, Dr. Naresh.
Yeah.
Yeah, though, like if you keep apart this FLORA trial, so most of the metastatic setting trial, they usually go for the PFS benefit most of the times.
Yes.
And then quality of life.
Yes.
These are the two things that most of the trials they try to see. Even if you go to Flora trial, it was not their primary endpoint to see your this one the PFS. It was secondary analysis which they have, I think, put, and after 2 years of the publication of the PFS benefit, in 2020 they came up with the OS benefit. So it's good to see that now trials are means giving us OS benefit also in metastatic setting.
Right. So yeah, coming back to the question, if you ask me, my personal experience with TKIs with gefitinib and osimertinib, I feel they're very safe drugs. They don't have very bad toxicities. So if a patient has a borderline performance status or a poor performance status, and if he's not fit for any therapy, and if he's EGFR mutant, I would take the leap of faith, obviously after discussing with the patient party. But I would be tempted to take the leap of faith and start him on a TKI, be it gefitinib or osimertinib, depending on how deep the patient's pockets are. And we do have patients who tend to make good recoveries, because mutated patients tend to respond very well to targeted therapies. I would definitely take that leap of faith. Anyways, so if we see the different trials which have compared TKIs, we find that osimertinib did provide the highest PFS, and it also included patients with brain metastasis. Next slide, please. Next slide. Yeah. So, Dr. Rajiv, I don't know, I mean, since you're from surgical background, do you feel that the type of mutations decide on the type of therapy that you give?
Sorry, Dr. Rajiv could not join yet. He is in an OT.
Okay.
Please continue.
Yeah. So, Dr. Dhitiman? So do you feel that you would change your therapy based on the type of mutations you get?
Yeah, surely. I think
So
I will
what would be your
change.
options?
And osimertinib, preferably osimertinib, I will try. If patient can afford.
In which type of mutations, sir?
This EGFR mutation, this yeah, both 19 deletion and exon 21 L858 are. I will try osimertinib.
Dr. Umesh, would you like to pitch in here? What's your thought on this? I guess Dr. Umesh is not with us. Next slide, please. So basically, the most common mutations that we get in EGFR, that is the exon 19 deletions and the L858R. There is good amount of data suggesting that all the TKIs work very well for these mutations, that is gefitinib, afatinib, dacometinib, and osimertinib. But when we see the PFS data, now again, this is a cross-trial comparison, so not an ideal situation. But if you see the PFS data, highest PFS is offered by osimertinib. So one mutational exception that I would consider is mutations in exon 21, which are classified as uncommon mutations or rare mutations, in which we have data that afatinib works well in these uncommon mutations. And there is more data for afatinib in these uncommon mutations compared to other TKIs. So for this small group of patients, say about 15 to 20% of patients who have these uncommon mutations, probably afatinib would be a better choice. But bearing that, for the common mutations like exon 19 deletion and L858R, osimertinib remains the drug of choice. Next slide, please. Next slide. Yeah. So next slide. Yeah, I think we have discussed this. So when we see the response rates as well as the PFS, osimertinib does stand out. Again, this is a cross-trial comparison, but only when we focus on the response rates, even the first and second generation TKIs do have a very good response rates to the tune of 75 to 80%. Next slide. Next slide, please. Yeah. So, Dr. Gautam,
Yeah.
how much importance would you place on the overall survival data whenever you are picking any drug, be it a EGFR TKI or a chemotherapy? How much importance you you put on overall survival analysis?
Yeah, see, you are talking of stage 4. So previously also I told you that usually we used to see PFS and quality of life in metastatic patient. But now this subset of patient like oligometastatic disease has come. The concept is fairly new, we have to say. And since we are dealing with such patients, so yes, OS has to be seen in this type of patients because we are handling this patient with curative intention. So systemic therapy plus some kind of local therapy to the oligometastatic site.
And in case of a purely metastatic setup, how much importance you put on overall survival data?
Yeah, that again will depend on the person's performance status, their economical background, everything we have to take into consideration if it is means a widespread metastasis.
Yeah, next slide, please. So I feel overall survival is probably the gold standard, irrespective, even in metastatic settings, because a therapy that offers overall survival benefit in first line actually has the potential or is capable of changing the biology of the disease and prolonging the life of the patient. Because if you see in the FLORA trial, almost 31% of the patients had a crossover, and despite this crossover, and after a good amount of follow-up period, as Dr. Gautam previously mentioned, after I think 3 years of the initial publication of the PFS data, they came up with the overall survival analysis. So despite of crossover, despite of extensive use of—
So once we have OS data, so everything means we can forget.
Absolutely.
OS is OS.
Absolutely. So that is why it is the gold standard. So any drug that gives an overall survival benefit obviously has, is definitely working. So when we see that the median the overall survival of more than 3 years with osimertinib, and I'm sure most of my colleagues would agree in their clinical practice that they achieve at least a median overall survival of 18 to 20 months in real life with osimertinib.
Yeah.
So with first line, an oral tablet with minimal side effects, a patient surviving for 2 years with metastatic lung cancer, I think you can't ask for more. So next slide, please. Next slide. Yeah, so when we see other oral TKIs, unfortunately, they haven't been able to show an overall survival benefit. They have shown a significant PFS benefit. Overall survival was not tested in the Archer trial with dacometinib because, as Dr. Venkat previously explained, it was a trial based on a hierarchical testing design where the overall response rate was not significantly different, so they did not proceed on to test the overall survival. Whereas in the Lux Lung trial, afatinib increased the PFS, but it did not improve the overall survival. Next slide. Yeah, so this is obviously endorsed by other consensus guidelines. Next slide. So, Dr. Rajiv is there with us?
No, he is not.
Okay. So, Dr. Dhritiman,
yes,
whenever we start a therapy for a metastatic lung cancer patients, do you consider that do you decide the therapy based on whether a patient means going forward whether he will develop brain mets or not? Do you give it a thought? Does that come in your consideration whenever you plan a therapy?
he can have brain mets.
Yeah, but then does that fact
that
influence
we'll
your
manage.
initial decision?
Yeah, that we have to, because patient is in advanced stage. So we have to keep in mind that he or she may have brain mets. And you have to, she is on follow-up, you have to take care of that also. And you have to notice whether if they are developing any such kind of problem.
Okay. Dr.
Yeah,
Umesh,
Dr.
that-
Naresh.
yes.
Yeah, can I pitch in?
Yes, yes, sir. Please,
Yeah.
please go ahead.
Yeah, if you forget about metastatic disease, even with localized lung cancer, 30 to 40% of the patient may harbor microscopic CNS disease, brain disease. So the guidelines they recommend that from stage 1B onwards, you have to do MRI of the brain during staging of the patient.
Yes, especially if you're going for a curative intent, it is mandatory that you image
Yeah.
the brain so that you don't miss occult brain diseases. Next slide, please.
Yeah.
So that's where our next question comes on. So how many of you actually look for brain mets in a proven metastatic non-small cell lung cancer? Dr. Umesh, or sorry, Dr. Kutum?
Yeah. Now, yeah, we are doing brain MRI now because
So
in
you
SCCA
routinely do
very
irrespective of symptoms?
Yeah, we are doing because it's very cheap out here now.
Okay. Anybody does a different practice to this?
No, usually we prefer this. We have to think for the patient pocket also. So CT, if possible, we do because it's cheaper than MRI. And MRI, for MRI getting time in, I don't know about your place, but in Agartala also, it takes 10 to 15 days. So you have to think CT you can do immediately. So depending on the patient's pocket and what facilities available, you can go for CT, or if you can do MRI brain, is good.
Okay, now with increased use of PET scan, I think if PET is not showing any CNS lesion, most would actually avoid doing a separate MRI because PET itself is quite expensive, especially in the Northeast, because of limited availability of PET. Previously, we at our center did not do a brain imaging, especially in asymptomatic patients. So if finances are a consideration, this is just a practical discussion. Theoretically, the guidelines say that all patients should undergo contrast MR or a contrast CT at least for staging. But for practical considerations, if the patient is asymptomatic, we generally do not image the brain. Next slide, please.
So actually, let me pitch in. So when I talked to a nuclear medicine specialist, so what he told me is that if there is isolated brain metastasis, single solitary, so sometimes it is difficult to comment for them. Okay. But if there is multiple brain mets, so what they are saying that PET CT can tell you about the disease, brain disease.
Actually,
but what
sir,
I was told that if there is single brain mets, so sometimes it is difficult for them to
Yes.
comment on that.
Yeah, I mean, if we see the way actually a PET scan or an FDG PET works, the background uptake of brain is so high that PET
glucose
very
uptake
poor
is very high.
sensitivity for picking up brain mets.
But if the patient is a multiple brain mets, then they can comment.
Yes. So again, if a patient has multiple brain mets, very likely that he would be symptomatic. So that becomes a consideration. So contrary to small cell lung cancer, wherein irrespective of symptoms, irrespective of stage, you have to image the brain. You can probably tweak in the data or tweak in the recommendations a bit in non-small cell lung cancer. Next slide, please. Yeah, so as I said, the guidelines mention that if even in a proven metastatic case, you do a brain imaging in order to document occult asymptomatic metastasis. Next slide. So when we see the efficacy data in terms of CNS metastasis, we know that first generation TKIs do not penetrate the blood-brain barrier, whereas the higher generation TKIs do tend to have some penetration to the blood-brain barrier. If we see the different trials, the Archer trial, which was designed for dacomatinib, actually excluded patients with brain metastasis. So obviously we could not know whether it works or not. But the Lux Lung 7 trial and the Flora trial included patients with brain mets, though the percentages were less than 20%. Both of these studies have shown some efficacy in terms of CNS response rates as well as CNS PFS. Next slide, please. Yeah. So if you see the CNS response rates with afatinib, you have a median CNS PFS of 8.2 months versus 5.4 months. Whereas in osimertinib, the CNS PFS is thumping 15.2 months versus 9.6 months. Now, why this becomes important is that we know that patients with CNS metastasis tends to have an inferior overall survival compared to those with non-CNS metastatic disease. Number two, we know that the quality of life of patients with CNS mets tend to be poorer compared to those with non-CNS metastatic diseases. If you are having a drug which penetrates the blood-brain barrier, which has a superior response rates in brain, and which has a superior PFS in brain, I mean, obviously that would be the drug of choice. In fact, many of my peers, many of my colleagues to whom I have spoken, they generally give osimertinib when it is feasible to patients with proven brain mets who are asymptomatic. And what they have observed, and this is my experience also, that you're able to delay brain radiation for a prolonged period of time, because most of these patients will have a CNS response with osimertinib itself, and you'll be able to delay the radiation in these kind of patients. I would like the radiation oncologist to pitch in here, Dr. Dhritiman. Hello. Okay, Dr. Gautam, would you agree to this, that osimertinib working well so that you can delay the radiation part?
Yeah. So what you have seen, it is according to the FLORA trial, because they have taken asymptomatic brain mets patient, not the symptomatic one. Okay. But with osimertinib, even if you require radiation in later part, what you can ask your radiation oncologist is that go for hippocampal avoidance radiation therapy. Yes. Okay, so this particular term has to be mentioned. Nowadays, it is the almost becoming standard of care. Yes. And even if the patient is not able to take osimertinib because of some economical issue, and you have to start with some gefitinib or erlotinib like that. So giving brain radiation, what it will do, it will breach the blood-brain barrier, and you will get some penetration of the first generation or second generation drugs into the brain. But whenever you are asking and you are almost sure that the patient is going to live for more than 6 months, kindly ask for hippocampal avoidance whole brain radiation therapy.
Absolutely.
Yeah.
Absolutely.
Yeah, Dr. Yadav, may I ask one question to radiation oncologist?
Yeah.
Yeah.
Yeah, actually, most of our practice is that if there is a brain mets, even if asymptomatic also, we are referring the patient to radiation oncologist.
Yeah.
What is your practice when you are giving radiation to the brain, even if asymptomatic patient also, and or only symptomatic patient?
So the thing is that when I was working in BBCI, so we used to see the patient whether they can afford osimertinib or not. If osimertinib, we keep the radiation in hold. But if the patient is not able to take osimertinib, then we offer whole brain radiation, but with hippocampal avoidance technique,
even
so that he doesn't lose his memory.
Also.
Pardon?
Even if asymptomatic patient, suppose
asymptomatic, but he has CNS disease, and the patient is not able to afford osimertinib, then we offer whole brain radiation with hippocampal avoidance technique.
Okay, suppose targeted driver mutation is negative, patient is on chemotherapy and he developed asymptomatic brain mets, and then that patient you are planning, you will give radiation.
Yeah.
Okay.
If the drug is not penetrating the blood-brain barrier, we have to give radiation, because that will breach the blood-brain barrier and make some of the chemotherapy drugs to have some CNS effect.
Okay, thank you.
I think Umesh da, when we are discussing this, one point is very clear that symptomatic brain met patients obviously will go for an upfront radiation.
Yes.
Symptomatic, there is no doubt. The question comes when there is asymptomatic brain mets. So asymptomatic brain metastasis patient, if they are able to afford osimertinib, I would start with osimertinib first and wait for the radiation part.
Yeah.
But I won't
that is what
have
I was practicing.
But I won't have similar level of confidence with gefitinib or chemotherapy. Obviously not with chemotherapy. I would prefer to radiate first, even if it is asymptomatic, before starting chemotherapy. And even with gefitinib, I don't get that degree of confidence in order to avoid radiation, even if the patient is asymptomatic.
Exactly.
That's my call, I think. That's my call.
No, that is the same line of work that I was doing till date.
Okay. Next slide, please. Dr. Tomar has joined, or we are still with, I think, only 2 panelists or 3 panelists. Dr. Tomar is with us, or?
No, he's not there. We have to
Okay,
continue.
okay. Dr. Umashankar, if this patient would be a metastatic non-small cell lung cancer with EGFR positive, with PD-L1 positive, would you change your upfront therapy? Considering that he has a very high CPS, suppose if he has a CPS of say 50, would you change your therapy, or would you still go with Dr. Umashankar?
Yes. With PDL1, I have only experience with one patient only, and that too, CFS was quite high, but still the response was not good. So during that time only, the EGFR report came back, but I could not use it because the patient already didn't come back for the follow-up. So yes, during till the reports come back, I can try the PDL1 patients.
Okay, Dr.
Hello?
Nabo, there with us. Naboda, you are
Hello?
there with us?
Yeah, I'm
Yeah,
listening.
what is your take on this scenario? Suppose PDL1 is very high, or CPS is like 50. Would you still change your therapy, or?
No, we know that if there is a harboring mutation, and in presence of if the PDL1, even if the PDL1 expression is high, so the response of the immunotherapeutic drug will not be good in those patients. And secondly, when we use if we use the PDL1 inhibitor upfront and then start with some anti-EGFR drug, then there will be much more toxicity to the lung. So that is the reason why, instead of having the high PDL positivity, I will definitely go with anti-EGFR drug.
Can we go to the next slide? I think the first part of the answer which Dr. Naboda mentioned is very important. In a patient who has a harboring targeted mutation and who also has a PD-L1 positivity, now there is ample data to show that these patients do not respond that well to immunotherapeutic agents. As it is, we know that response rates with immunotherapeutic agents are low, but moreover, in patients with driver mutation, the response rates tends to be extremely poor. So there are, you can see in this diagram also, in the forest plot, most of these patients who have EGFR mutant in all of the trials, the line crosses the median. So they don't do well with immunotherapy. Next slide. So much so that there are recommendations saying that in second line, wherein patient has exhausted a first line TKI, in second line, it is better to combine immunotherapy with chemotherapy rather than giving immunotherapy alone. And this is irrespective of high PD-L1 expression or tumor mutation burden. Next slide. Yeah, can we go to the next slide? Yeah. So, Dr. Umashankar, what is your experience about toxicity of different TKIs? You must have used the different generation TKIs in your practice. How comfortable are you in managing the toxicities, or which drug you find particularly difficult?
Mainly, we are using most of the patients are getting our gefitinib, erlotinib, these two drugs only. So they have most common toxicity as skin rashes, itching, skin changes, and hypopigmentation or hyperpigmentations, and raise in AST or ALT levels. This toxicity are easily managed.
But manageable, yeah, exactly.
Yeah, easily manageable.
Okay. Dr. Rajiv Paul. I'm sorry, there are hardly any surgical questions here, but yeah, any experiences with or any experiences from your colleagues in medical oncology? How do they
I have
find?
an interesting experience with osimertinib. The patient who was receiving osimertinib, he had this low platelet count around 30,000-40,000. So I inquired about if there is I charged the literature if there any treatment regarding this. So I couldn't find anything regarding whether it is if we can reduce the osimertinib dose or not. If it can be given in 40 mg. So I searched. We look around. The osimertinib 40 mg is not available throughout India. It is available outside of India. And what we did is I alternated those. She was taking one day osimertinib, next day off, and again he took osimertinib on the following day. That we practice for around weekly with platelet count check. Within 1 month, her platelet got recovered. Then again we started on full dose TMG osimertinib. Then her platelet was normal throughout till now. That's my experience with that. Only one I want to share with you all.
Okay. I mean, that could be a situation in which the thrombocytopenia might be due to marrow involvement with non-small cell.
Yeah,
lung.
marrow involvement. Yeah.
Yeah, that might be the possibility which responded and the patient's counts recover. Anyways, I think all of the oncologists who have used these drugs would share the similar experience that TKIs are fairly well tolerated. And gefitinib and osimertinib are probably the two of the most safest TKIs. In fact, FLORA trial said that the grade 3 adverse effect was to the tune of 34%. I generally believe it's a very safe drug. I have not encountered many adverse reactions which are grade 3 and above with osimertinib. And I guess most of the oncologists who have used these drugs would agree to this. I have not had any experience with dacomatinib, but afatinib is slightly difficult to tolerate. You tend to have a lot of mucositis, fatigue, and transaminitis with afatinib. So next slide, please. So the second generation TKIs do tend to have a slightly more unfavorable toxicity profile with higher grade 3 adverse events reported in literature with dacomatinib and afatinib. And so they are slightly more difficult to tolerate compared to the third generation TKIs. Next slide, please. So this is what this slide also mentions, that we have a higher incidence of dose reduction with afatinib and with dacomatinib, whereas the dose reduction was very less to the tune of 4% with osimertinib. Next slide, please. Next slide. So obviously the quality of life does matter when we talk about a metastatic setting, because that is the first aim of an oncologist who treats a metastatic patient, that even if he is not able to prolong the quantity of life, at least improve the quality of life. And if you see the different trials, they all included quality of life analysis as a parameter. Next slide. And we can see that with the FLORA trial, can we go to the next slide? Yeah, we can see with the FLORA trial, with respect to different symptoms like cough, dyspnea, chest pain, appetite loss, and fatigue, all of these responded well, which indirectly translated to a better quality of life. Now, this basically indicates that the response rates of the drugs are better, because a drug that responds better will obviously translate into a superior quality of life. Whereas in the ARCHER trial, when we see dacomatinib, in terms of symptoms due to the disease, there was improvement in the quality of life, but the drug being slightly difficult to tolerate, causing side effects like diarrhea and sore mouth, in that aspects it deteriorated the quality of life. Next slide. So generally, a drug which has a higher side effect will implicate the quality of life versus a drug that has lesser side effects, irrespective of the whether both of the drugs are equally active. Next slide, please. So in terms of sequencing, next slide. Yeah, next slide. I think Dr. Venkat and Dr. Umesh has probably explained this very well in their discussion. Next slide, please. One of the major issues with sequencing is that this is a slide from Dr. Umesh sir's presentation. One of the major issues with sequencing is that most of the patients do not go on to receive the second and third line of treatment. The development of T790M mutation is very erratic, and you cannot predict which patients develop these mutations. Another problem with sequencing is that if the patient develops brain metastasis, even if you sequence an osimertinib, the quality of life doesn't remain the same as avoiding a brain metastasis, which you can do when you give an upfront third generation TKI. Next slide, please. Next slide. Yeah. So to conclude this, we know that osimertinib has a significant improvement in PFS over the standard of care, and we have a PFS to the tune of 18 months. Osimertinib is the only drug that has demonstrated a statistically significant and a clinically meaningful overall survival benefit, as well as a CNS PFS benefit compared to other TKIs. You have about 30% of patients that are alive at 3 years with osimertinib, and this you do not get with any other comparator EGFR TKI. To top of it, osimertinib is a very safe drug, and it has a very safe, favorable toxicity profile. So we have a win-win situation on both ends of efficacy as well as toxicity. Next slide. Thank you very much. With this, I'd like to conclude this session, and I would like to thank all my panelists. Dr. Tomar unfortunately couldn't join us. Dr. Umashankar Kutum from Dibrugarh, Dr. Gautam Sharma sir from AIIMS Guwahati, Dr. Rajiv Paul from State Cancer, and Dr. Nrityaman Datta from Agartala, sorry, for their active and wonderful participation. Thank you very much. I think this would be the last slide. Yeah. Back to the organizers.
Thank you, sir. Thank you very much for the wonderful panel discussion. Now I would request Dr. Umesh Das for concluding remarks.
Yeah, thank you all for nice presentation, all the speaker, all the panelists and moderator for panel discussion, and all the speaker for nice presentation.
Umesh sir, could you please switch on your camera, please?
Yeah. Thank you all, and thank you especially Mr. Bahar Talukdar for organizing this webcast CME. He was planning for last I think 6 months for regarding this. We will make one CME with Dr. Naresh, and other doctors from Assam Cancer Foundation and GMCS, SCI and BBCI. So thank you, Bahar, and thank you AstraZeneca and Intas and LKM for sponsoring this event, and thank you audiovisual team for this event.
Thank you, sir. Thank you, everyone. Thank you, Bahar, and thank you.
Thank you so very much, sir. Thank you, everybody. And
thank you, everyone.
Thank you, everyone, for
Vishal,
joining.
Team, thank you very much. Nicely have organized this, and all the speakers, all the participants, we thank from the core of our heart, because at this late hour Saturday evening you took out your time and you have given to us and enlightened us with the lung cancer, the scenario, as well as the treatment protocols. You have taken through us. So it is, thank you all the doctors. Thank you so very much, and have a good night.
Thank you, sir.
I have a question. Excuse me.
Yes,
Hello?
yes, Uma.
When will the price will decrease?
This question to Mr. Bahar.
Sir,
Bahar,
as of, we don't have any information.
It has some lots of benefit. We request. We would like to highly use this drug.
In fact, sir, we have also requested. So company has reduced. Earlier, it was MRP was like around 2 lakh, about 2 lakhs. We have reduced to 1,51,000. And patients used to get around 1,80,000. Now patients are getting at the price of 1,21,000. And we are giving like patient assistance is there. So this much help we are giving as company. So maybe it is taken to the global, like, because since a multinational company, so it's domestically we cannot take any decision. So we are waiting for the, like, let the higher authorities take the decision. We are also expecting it is, if it is reduced, then definitely our more number of patients will be get benefited out of it. Thank you so very much, everyone.
Thank you.
It was pleasant to have you all, and have a good night.